Thank you. Yeah, I need the stairs. If anybody's going to fall and crack their head and cause a great disaster, it will be me. So yes, important to say I don't have any conflicts in this area. I'm really excited to come and talk to you today because I speak about cannabis all the time, mostly in a medical education context, and so it's nice to have a whole bunch of fresh ears who haven't been forced to listen to me dozens of times. My one bias is probably that I am a chronic pain physician, so I speak to this from the perspective of a chronic pain doctor. So I'm talking about the things that I hear from the patients that I talk to every day, many of whom do use cannabis to help mitigate their symptoms or recreationally. So I'm not talking about all of these other conditions that are not my area of expertise. I'm just really talking about chronic pain. And I'm not talking about legalization either. I think it's really important to understand that those are, in terms of the medical evidence, two really different questions. So what I'm going to try to do in hopefully less than 15 minutes, maybe 12 minutes, is try to separate kind of what we know about cannabis from what we believe to be true about it. When we talk about cannabis in the pain and authorizing cannabis scenario, we're really asking the question about whether cannabis is medicine and what do we mean when we say that something is medicine. And then very briefly, just a couple of words maybe on where the medical authorization system might go in the context of legalization, understanding that that is pure crystal ball gazing. We have really no idea at all. One thing that I have been reflecting on as I've been listening to the speakers so far is what would be a really, really dangerous drinking game is if you looked at the live stream of this later and take a drink every time somebody says, "We don't know," or "probably," or "maybe," or "we're not really sure." Really dangerous, do not do that. So when I talk to people about cannabis, they tend to come at it from one of two very polarized positions. So either they're the Ozzy Osbourne sweet leaf camp, which is everybody should have this in their house, and there is nobody who is going to be harmed by this. It's good stuff, everybody should have it for virtually every condition. Or it's turning society into zombies. It's the slippery slope to the end of civilization as we know it. And so I try to take somewhat of a more middle ground and really talk about what does the evidence tell us? What do we know? And so when I talk to medical students and residents about this, we always start with a bit of a brainstorming conversation about what makes something medicine. And so distinct from what makes it medication. So in the context of these discussions with medical providers, we tend to think of those two words have different connotations. But the medical students and the residents always tend to come up with relatively the same list of things that makes something medicine. One thing is that it has to be therapeutic in some way, right? It does something positive, it treats something. The safety issues are relatively well understood, which doesn't mean that it's safe or safe for everybody, but it means that we have an idea of what the big safety issues are. And that it has some predictable effects in the body, so that I can have an informed consent conversation with the patient and say, this is what I think this is happening in your body in a relatively predictable way. So one of the things I sort of feel like I could probably go home now because between the things that Matt talked about earlier, Aleem's comments, the really articulate stories that we heard from patients, I feel like I'm not going to be saying a lot that's super new. But really, there is an enormous body of anecdotal evidence that cannabis is helpful for all kinds of conditions. So if you Google any one of these conditions and cannabis, you'll find case reports of patients saying, this was really helpful for me, changed my life. In a positive way. Or physicians saying, I have this patient with back pain who did really, really well. And so that's really important information. It's not the highest possible level of evidence, we need more, but it's the thing that starts off our conversation. And I think that's really important to highlight. One of the things that Aleem said, long history in medicine of our advances coming from really listening carefully to patients and what they tell us. They're taking a blood pressure medication and they come back to their doctor and say, oh, by the way, I haven't had any migraines since you started that blood pressure medication. So we listen to that and we study it and we figure out what it's about, and then next thing you know, beta blockers are a standard treatment for migraine. But it starts with really carefully listening to what patients are telling us. At the end of the day, though, and I think Matt made this point too, when this is a comprehensive and complete list of the things that are clearly proven in terms of the risks and benefits for pain patients in particular of using cannabis. I even have references. Really, anybody who's written a major review in this topic says, we don't really know what we need to know. So there are big gaps in our knowledge about cannabis and its effects in people. These are the sum total of the 6 randomized controlled trials that have been done in chronic pain in cannabis. So 6 of them. I'm not going to go through each one of them in general, but I'm going to tell you in general what they have in common. They're pretty small studies. They're pretty short studies. And all of the participants in all of the studies were previous users of cannabis before they started the trial. So that's distinct from medications that have been approved by Health Canada. If you look at those studies that those are based on, typically they're studies of hundreds of people for 6 months or more, and most of the time you wouldn't enroll somebody in one of those studies if they'd previously used the study drug. So we can't generalize, we can't take this study and generalize it to a big population and say that it's true of everybody. It's only true of the people who were in this study. The other thing is they were really small doses. So the doses that have been studied are fairly small in comparison to what most people in Canada are using. They were all of these studies were studies of smoking or vaporizing cannabis, so none of them were oral use or topical use. There have been no studies in pain in those areas. But at the end of the day, there was a consistent reduction in pain, ranging from 0.7 to 3 on a 10-point numeric rating scale. So if your pain was 6 out of 10 at the beginning of the study, it would come down somewhere between 0.7 and 3 points. So again, not the level of evidence that we would typically have for something that's a Health Canada approved medication. Important to say, I'm not saying that these are bad studies. These are exactly the kind of studies that need to be done when you're taking those patient stories and trying to move that into the realm of evidence. This is exactly what you do when you're at that stage. But now we need more. There are a couple of systematic reviews that you'll see sort of floating around talking about cannabinoids. These, to my mind, kind of cloud the issue in a little bit because these are talking about every medication that acts on your cannabinoid system. Matt talked earlier about synthetic versus the phytocannabinoids, and those many of the medications that are cited in these studies are things like nabilone and nabiximols and things like that. So really, all of these studies are still just looking at the same 6 randomized controlled trials that I told you about. So there's consistent evidence in the studies that have been done so far that there's a significant potential here for reducing pain. But when we talk about cannabis in general, we're talking about a lot of stuff. And so when you ingest it in any way, smoking, vaporizing, oral use, you're taking in about 400 different chemical compounds, about 100 of which we think are cannabinoids. And really only 2 of those cannabinoids have really been studied to any great extent, and that's THC and CBD. And so if you were taking note of how many times in Matt's presentation he said, we don't really know, this slide kind of gets to the crux of why physicians sometimes are uncomfortable having these conversations about cannabis as a medication, because it just feels like there's a lot that we don't understand. And the same thing is true when we're talking about the safety issues. So there is fairly significant evidence of some harms that happen for some people. And obviously it's like every other medication, not every side effect happens to every person. But our data around the harms, as Matt described very clearly, is really based on population epidemiologic studies of people who use cannabis recreationally. So there's big differences between people who use it recreationally and people who use it in a clinical prescribed context. So does it make a difference if people are using it every day? Does it make a difference what dose they're using? Does it make a difference what conditions they have coming into the period of use? All of those things are things that we don't know. So when we're trying to weigh the risks and benefits, on both sides, the risks and the benefits, it becomes a little bit difficult to quantify that. And we're all about quantifying things. There's a really good review of the literature that was done by the National Academies of Science, Engineering, and Medicine in the US, just came out in January. And so they sort of make a similar point, that there is really good basic science evidence that THC in particular probably has analgesic properties. It probably is good for pain. But what they note in this report is that smoking cannabis is kind of a crude way of delivering THC, and it comes with a whole bunch of baggage that we don't really completely understand. And so they made the point strongly that we need a lot more research to figure out what we're meant to do with that. Maybe 90% of that other stuff is completely harmless, but it, at this point, hasn't been studied. So one of the things that I alluded to earlier is the kind of predictability about what happens in your body when you use a substance. And inhaling cannabis is pretty straightforward from that perspective. So whether you're smoking it or vaporizing it, it has a fairly predictable effect in terms of blood level in your body. So if you use this amount at time period X, your blood level will be Y. That, unfortunately, is not the case of oral or topical use. So that's one of those areas that hasn't been as well studied, but we do know that it's a lot more variable. So the effect of an oral use of a cannabis agent in me is going to be really different than it is in you, and it's going to be really different in me today than it's going to be tomorrow if I skip breakfast tomorrow. So that kind of predictability, it makes it really difficult to study the oral products, which is one of the reasons why there haven't been studied randomized controlled trials to this point. So again, the National Academies report says we need, one of the really urgent needs in terms of research in this area is trying to figure out how to deliver that THC in the most predictable and the safest possible way. So when it comes to legalization, I could talk for days about medical impacts, and you're going to hear all about all kinds of those things today. From my perspective, I am thinking a lot lately about what the impact of legalization is going to be on the medical authorization system. And so myself and a lot of my colleagues who authorize cannabis have been spending a long time poring over the task force report and trying to figure out what that potentially signals for us. I really, really like the metaphor that they use at the beginning in the introduction of the task force report, where they talk about it being like scraping ice off of a car window on a cold morning. And I think they're really acknowledging the big gaps in the literature that we have. But I also really like this metaphor because it feels like you can carry this metaphor on and really say, you know, some people are really comfortable getting moving in the morning with a fairly small window. And some people really need every sliver of ice off the windshield before the car goes into drive, right? So I think that's a really nice illustration of why we have some conflict about whether or not we can move forward. Some people are just more comfortable moving ahead with a little bit less of that randomized controlled trial evidence. So really, at the end of the day, the task force report said we really have no idea what's going to happen to the medical system in the context of legal cannabis. And so their recommendation was really just, okay, let's keep it going exactly as it is right now, and in 5 years, let's look at it again and see if we still need it. Many of us feel like, you know, at the end of the day, if my patient has legal access to cannabis and can deal directly with licensed producers, then my role really is going to be quite a lot smaller. So it's possible that we're going to see a situation 5 years from now where people are mostly coming to their doctor for authorization because they need a note for insurance. So if you want it covered by a third party, you likely will need a doctor's note, and at the end, other than that, your doctor may not play a big role in it. But I feel really strongly that I was absolutely horrified by Holly's story. I can't even put into words how horrifying that is to me, because I really feel like your family doctor should at least be able to have an open, respectful conversation with you about it, whether you're using it for medical purposes or using it for recreational purposes. We spend a long time talking to medical students and residents about how to talk respectfully to a patient about alcohol, and whether or not their alcohol use is within a safe window. And we need to be able to have those same conversations with people who are using recreational cannabis too, whether it's legal or not. And so a lot of what I do is about just trying to open up those conversations and trying to make sure that we can find some common ground in our discussions, because as everybody so far has said, patients are telling us something that I think is really important to listen to, but we can't stop there. That's not enough. We can't stop with my patient Joe with back pain did really well with cannabis. We need to move on and figure out how to pick the right patients and what doses to use and what products and what conditions and how are we measuring success when we're prescribing these agents. So I think this whole day is going to be really exciting for trying to open up some of those conversations. So I will open it up for the next person, but I look forward to some good discussion at the end.